Good morning, everyone. We are delighted to have Dr. Amber Molnar from McMaster present to us today on Dialysate Bicarbonate, tricky balancing act, pun in there. So Dr. Molnar is Associate Professor at McMaster, and she's a nephrologist at the St. Joe's Healthcare Hamilton. She did her training in her medical training at Saskatchewan, internal medicine residency at Western, and then she was a nephrology fellow at the one of the best programs in the country, if not the world, in Ottawa. She went on to do a research fellowship where she also did a master's in ClinEpi here, and then got her faculty position at McMaster. She's an ICS Adjunct Scientist as well. And she's got an interest in people in taking care of people with advanced kidney disease as well as in pragmatic trials, which is where I think her talk today is going to be on bicarbonate. Welcome, Amber.
Okay, so thank you for that introduction and thank you for the opportunity to present today. So these are my objectives. I'm first going to talk about the relationship between dialysate bicarbonate concentration and patient acid-base status, followed by describing the association between dialysate bicarbonate concentration and patient outcomes. And I'll end by talking about the Dial Bicarb trial, which is a trial that we recently received funding for and hopefully will be launching within the coming months. So these are the recommendations that we have in terms of treating metabolic acidosis in patients with kidney failure on dialysis. And the recommendation is really to maintain a normal pre-dialysis serum bicarbonate concentration, which is defined by at least 22 millimoles per liter. But you'll see that this is opinion-based, and really it's based on fairly weak evidence. So what evidence do we have that has informed this guideline? So we know that chronic metabolic acidosis can result in complications for our patients. And the complications that we probably worry about most are bone demineralization, which can potentially increase the risk of fractures, and also muscle mass loss, which could potentially increase frailty for our patients. There are also a number of large observational studies that have included thousands of dialysis patients, which have shown an increased risk of mortality associated with metabolic acidosis. And this figure is taken from a DOP study. And this study showed that there was the highest risk of mortality in patients in the lowest quartile of pre-dialysis serum bicarbonate. And this result has been replicated in a number of different studies. So what about the benefits of actually reversing or treating metabolic acidosis? This is where we really do not have a lot of data. We do have some fairly small randomized trials in patients receiving peritoneal dialysis, which have demonstrated a benefit of giving oral bicarbonate supplementation with the goal of normalizing the serum bicarbonate. And this has been shown to reduce hospitalizations and improve nutrition. We have some pretty small interventional studies in patients on hemodialysis, which are not necessarily all randomized. So it has been demonstrated that using a high dialysate bicarbonate concentration of up to 40 millimoles per liter can suppress PTH secretion, increase triceps skin fold thickness as a marker of nutrition and reduce frailty, and correction of acidosis with oral sodium bicarbonate, again in a very small study, was shown to increase insulin sensitivity. But we also have a number of small studies that have shown no difference in serum albumin as a marker of nutrition. So not really a lot of data showing a difference in clinical outcomes with actually treating metabolic acidosis. But it's based on this data that we really have focused on the pre-dialysis serum bicarbonate and reversing and treating metabolic acidosis. And we do so either by prescribing oral sodium bicarbonate or prescribing very high concentrations of dialysate bicarbonate. So those are really the two approaches for our patients on dialysis. So what do we actually do here in Canada in terms of alkali replacement? So we conducted an informal online survey of programs across the country. And we asked nephrologists if they are actually giving any oral bicarbonate supplementation to their patients on dialysis. And as you can see, at least in Canada, this really is not happening. Most of the respondents said that they never or only very rarely under specific circumstances do this. So this means that in terms of hemodialysis patients, the reversal of metabolic acidosis is occurring based on the delivery of alkali during the dialysis treatment. And we all know that hemodialysis is an intermittent treatment. Most patients are coming in center only 3 times per week. And so this then results in very large shifts in their acid-base status, where they're relying on alkali delivery solely during the dialysis treatment. So they may start off with a lower pre-dialysis serum bicarbonate, and then there's this very large shift or change in their serum bicarbonate during the dialysis treatment, such that they may be leaving dialysis with actually a very high serum bicarbonate concentration, which will then drift down in between the dialysis sessions. This is obviously not very physiological, and so could be resulting in potential complications for our patients. So what are the practices with respect to dialysate bicarbonate? And this is DOPS data. This data is getting a bit old. This study was published in 2013. It included more than 17,000 patients across 11 countries. Canada is included here. There's also US data. And as you can see, practices really do vary across countries. There are pretty high concentrations used in North America, in particular in the US. There are a lot of patients receiving a dialysate bicarbonate concentration more than or equal to 38 millimoles per liter. In Canada, most patients are receiving a concentration between 33 to 37. The practices in other countries are quite different, in particular Germany here. The majority of patients receive lower concentrations at less than or equal to 32 millimoles per liter. We wanted to look at this based on more current data. So again, we did an informal online survey of programs across the country, and we did find that practices really do vary depending on the center and depending on the region. So there are some centers that are practicing something called individualization. So where they decide on the dialysate bicarbonate concentration to prescribe to the patient, depending on their pre-dialysis serum bicarbonate concentration, which is measured as part of monthly blood work. And then they're using a range of concentrations anywhere from 30 to 40 millimoles per liter. We also found that there were some programs using concentrations as low as 30 to 32 millimoles per liter as more of a standard practice. So a standard practice means that these units are prescribing the same concentration to nearly all patients in the unit. There were a lot of programs using 35 millimoles per liter, and then some going up as high as 40 millimoles per liter. So really a wide range of practice. We recently performed a systematic review and meta-analysis in this space. This is unpublished data. Here we looked at the impact of dialysate bicarbonate concentration or oral bicarbonate supplementation on a variety of outcomes in patients on both PD and HD. We included 36 studies in this review. There were 12 randomized control trials that we found. The largest trial was still fairly small, including only 93 patients, which I think is typical for a lot of areas of nephrology. None of the trials were examining hard clinical outcomes such as mortality or hospitalizations. So this slide and the next slide summarize some of the randomized control trials included in our review, and these are specifically the trials that looked at differing concentrations of dialysate bicarbonate. And as you can see, they're all pretty small. They have compared different combinations of dialysate bicarbonate concentrations and all looking at fairly surrogate outcomes such as serum albumin or pre and post laboratory measures and some surrogate cardiovascular types of outcomes. So we did make an attempt to do some meta-analysis of the data, but we were limited in our ability to do so because of the differences in the intervention groups across the studies and the limited number of randomized control trials. We wanted to, however, look at the impact of the dialysate bicarbonate concentration on the pre-dialysis serum bicarbonate concentration. And so we were able to meta-analyze 3 of the trials that we included in our review. And when we did so, we found that there was a mean difference of 3.5 millimoles per liter in the pre-dialysis serum bicarbonate concentration with a higher dialysate bicarbonate concentration. We then removed this top study here because it did look like the patients included in this trial were somewhat different than the average dialysis patient, especially in the modern era. And the difference was then attenuated, and only a difference of 1.5 millimoles per liter was found. And again, this lower limit of the 95% confidence interval was crossing 0. So really not a significant difference or significant impact. We also recently looked at this using our own data from across Ontario. This is not randomized, obviously, observational. We were able to use ICS data to look at the association between the dialysate bicarbonate concentration and pre-dialysis serum bicarbonate concentration. And we determined the dialysate bicarbonate practice by surveying the various dialysis programs across the province. And we took advantage of the natural practice variation that exists across Ontario to look at this. So in the end, we included over 5,400 patients in our cohort. And our exposure was the dialysate bicarbonate practice of the center. And so some centers were using this individualized approach, making adjustments usually dependent on the pre-dialysis serum bicarbonate concentration. And then others were using a standardized approach whereby almost all patients in a unit just get prescribed the same concentration. And these units prescribed either 35 millimoles per liter, somewhere between 36 to 37, or upwards of more than or equal to 38 millimoles per liter. And our primary outcome was the mean outpatient pre-dialysis serum bicarbonate concentration over a follow-up period of a year. These are some selected baseline characteristics across the various exposure categories. So they were pretty similar. There are some differences here in this 36 to 37 millimole per liter category, likely just by chance due to the fact that there's a relatively small number of patients in this category. They were a bit older and more likely to be male. Patients in the higher dialysate bicarbonate category did have a slightly higher baseline pre-dialysis serum bicarbonate, but of only about 1 millimole per liter. And you will notice that all of the categories had a normal serum bicarbonate concentration that is actually in the upper limit of normal. When we looked at the mean serum bicarbonate by dialysate bicarbonate category over the entire 1-year follow-up, we found again that those in the highest category had a slightly higher pre-dialysis serum bicarbonate, all in the upper limit of normal. We then looked at this using linear mix models where we could adjust for some differences in baseline characteristics and formally look at the association between the concentration of dialysate bicarbonate and the serum bicarbonate over the follow-up. We compared individualized to standardized and then the various standardized categories. You can see here that there really was no significant or meaningful differences across the various categories. When we limited things to the standardized categories and used 35 millimoles per liter as the referent, we did find that those in the greater than or equal to 38 millimole per liter category had a slightly higher pre-dialysis serum bicarbonate concentration. This was statistically significant. It was slightly attenuated upon adjustment. And how you interpret this is that those in the higher category had, on average, a 0.9 millimole per liter higher pre-dialysis serum bicarbonate concentration. So although statistically significant, I think it's of questionable clinical significance. We also looked at a number of different subgroups. We selected COPD because there is some data to suggest that patients with lung disease, in particular those who are CO2 retainers, may have differing bicarbonate levels and also may experience worse outcomes with the use of higher dialysate bicarbonate concentrations. So we were interested in this subgroup, and we do plan to look at this subgroup as part of the trial. We found, again, no meaningful differences across the various subgroups. These results that we found with Ontario data, with there being very little impact of dialysate bicarbonate concentration or practice on the pre-dialysis serum bicarbonate concentration, have also been replicated in the DOPS data. So when they looked at this, they found a very weak correlation between the dialysate bicarbonate concentration that was used and the pre-dialysis serum bicarbonate. They also found, similar to us, that using an individualized approach to this really did not result in a meaningful difference in the pre-dialysis concentration of bicarbonate compared to using a blanket standardized approach. There are some limitations to our study. So firstly, we could not directly confirm that all the lab data were actually pre-dialysis, but we limited it to outpatient measures. So we feel pretty confident that almost all of these measures would have been drawn pre-dialysis. Unfortunately, we did not have any patients in a standardized category that received a concentration less than 35 millimoles per liter, so we could not look at this exposure category. And we don't actually know what the prescribed dialysate bicarbonate was for each dialysis session. We only inferred this indirectly based on our survey data. And then we did not have access to pH measurements or post-dialysis measurements. We don't routinely measure post-dialysis bicarb or pH. So what is the impact on the post-dialysis measures of serum bicarbonate and pH? This has been looked at in some of the small trials that were included in our review. So this figure is taken from actually the largest trial in this space that included 93 patients. And here they took patients on hemodiafiltration and randomized them to either 34 millimoles per liter or 30 millimoles per liter in terms of dialysate bicarbonate concentration. They then measured the pre-dialysis serum bicarbonate and found really very little difference. When they measured the post-dialysis serum bicarbonate, they did find more of a difference, and those in the higher group were leaving with a serum bicarbonate in the alkalotic range at 28 millimoles per liter. So what about pH? This has also been looked at in some small trials. So this is a figure from a crossover trial that included 46 patients, and they've compared 3 different dialysate bicarbonate concentrations. On the bottom, you have those in the lowest concentration group of 30 millimoles per liter. They were on average coming into dialysis with a pH of 7.38. Those in the highest concentration group of 40 millimoles per liter were coming into dialysis with a mean pH of 7.42. By the end of dialysis, patients in the highest concentration group had a pH of 7.52, so they were leaving dialysis with a metabolic alkalosis. Again, this has also been looked at in a prospective cohort study. This included Japanese dialysis patients, 53 patients included. They tend to use lower dialysate bicarbonate concentrations in Japan. Here they compared 25, 30, and 35 millimoles per liter. They looked at both arterial pH pre and post dialysis and bicarbonate pre and post dialysis. There was very little difference in the pre-dialysis values, but the post-dialysis pH and bicarbonate were well into the alkalotic range in the 35 millimole per liter group. So just to summarize this relationship between dialysate bicarbonate concentration and patient acid base status. So there is this common practice of individualizing the dialysate bicarbonate concentration and also using fairly high dialysate bicarbonate concentrations. And these practices are both driven by this goal of normalizing the pre-dialysis serum bicarbonate concentration. And this is what is recommended in our current guidelines. But I hope I've convinced you from the data presented that these practices really do have a very limited impact on the pre-dialysis bicarbonate and pH. So it's probably not as simple, or we're taking an overly simplistic approach by just consistently ramping up the dialysate bicarbonate concentration with this goal of normalizing the pre-dialysis bicarbonate concentration. And we might actually be causing harm for our patients because this practice could induce a significant post-dialysis alkalosis, which we don't tend to look for or measure. So what about the association of dialysate bicarbonate concentration with clinical outcomes? And this is where we really do have very little data. So this is, again, the DOPS study that included more than 17,000 patients across 11 countries, including Canada. And as part of this study, their main purpose was to look at the association between dialysate bicarbonate concentration and mortality and hospitalizations. And they were able to adjust for a number of different patient and dialysis related factors here. And they demonstrated that there was an increased risk of all-cause mortality, and in particular, infection-related mortality in those being prescribed a higher dialysate bicarbonate concentration. They also showed an increased risk of all-cause and cardiovascular specific hospitalization. So this is observational data. So it's really hard to tease out, is this causal or is this potentially due to residual confounding? One thing supporting that there is potentially something causal here is that the association was stronger in patients with a longer dialysis vintage. They also looked at this by dialysate bicarbonate concentration category, and again demonstrated this pattern or linear trend of increasing mortality with increasing dialysate bicarbonate concentration. And this was also consistent across pre-dialysis serum bicarbonate categories. So again, this begs the question, how much of this is due to residual confounding? There is certainly the possibility of confounding or bias by indication. So patients who are prescribed a higher dialysate bicarbonate concentration may potentially be sicker or more prone to metabolic acidosis, and this could in part be driving the increased morbidity and mortality. But this could also potentially be causal, and it's impossible to determine this for certain based on the observational data. But there are definitely potential causal explanations for this result. So as I've shown, there is a rapid increase in the pH and serum bicarbonate concentration during the dialysis session with the use of these high dialysate bicarbonate concentrations, which are quite common in clinical practice. And these large changes in induction of metabolic alkalosis may potentially increase patient morbidity and mortality through these proposed mechanisms. So there could be respiratory changes, in particular in patients with respiratory disease, with increased hypercapnia with the use of higher dialysate bicarbonate. The metabolic alkalosis could be driving electrolyte imbalances such as hypokalemia and hypocalcemia that could potentiate arrhythmias, hemodynamic instability. There's less data for this, but metabolic alkalosis could potentially increase the risk of progression of vascular calcification. And then there's this issue of the increased risk of mortality specific to infection that was seen. And there's not really a lot of data in support of a causal mechanism for this, but there is some data suggesting that antigen-presenting cell function is impaired in the setting of metabolic alkalosis. So potentially the use of higher dialysate bicarbonate concentrations is contributing to immune system deficiencies, thereby increasing the risk of infection. So a number of potential pathways by which this could increase the risk of death. So What is there any literature in support of these causal mechanisms? So this is a very small trial that looked at a dialysate bicarbonate concentration and potassium post-dialysis and potassium removal as well. It only included 8 patients. It was a randomized 3-sequence crossover study that compared 3 different concentrations. So they looked at 27 millimoles per liter as a low concentration, 35 was the standard, and then 39 millimoles per liter was the high concentration. And then they looked at potassium concentrations throughout the dialysis session. All of these patients were dialyzed against a potassium concentration of 2. And those in the highest category of dialysate bicarbonate concentration had the lowest serum potassium by the end of the dialysis session, and those in the lowest dialysate bicarbonate group had the highest potassium. So this is likely primarily due to increased intracellular shifting of potassium with the higher dialysate bicarbonate concentration. And this is supported by the fact that they also looked at potassium removal. And they found that those in the lower dialysate bicarbonate category of 27 millimoles per liter here in the gray bar actually had the greatest amount of potassium removal on dialysis. So if patients are having reduced potassium removal with dialysis when we use these very high dialysate bicarbonate concentrations, does this impact the increased risk of rebound of potassium and possibly impact the pre-dialysis potassium value? Well, we looked at this as part of our systematic review and meta-analysis. So here we meta-analyzed on the top trials that compared intervention groups of greater than 35 to less than or equal to 35 millimoles per liter, and on the bottom greater than or equal to 32 or less than or equal to 29. And these trials measured the pre-dialysis potassium as one of their outcomes. And we found that there was overall no difference whether you used a higher versus lower dialysate bicarbonate. We did, however, find in the trials included in our review, and this is consistent with that very small trial I just presented, that there was a difference in the post-dialysis potassium. So in the higher dialysate bicarbonate group, the post-dialysis potassium was slightly lower. This result was statistically significant, but it's only a mean difference of 0.2 millimoles per liter. So overall, pretty small. We also looked at both pre and post dialysis ionized calcium. Here on the top, you have the pre-dialysis value, and on the bottom, the post-dialysis value. There was no difference in the pre-dialysis value, but similar to potassium, the ionized calcium post-dialysis was significantly lower in the higher dialysate bicarbonate group. Again, though, although statistically significant, a pretty small mean difference of only 0.05 millimoles per liter in the ionized calcium. We also did look at pre-dialysis potassium and calcium values as part of our observational ICES study. And when we looked at this, we found no difference in the mean potassium value over the follow-up across the different exposure groups. And again, we found no meaningful differences in the pre-dialysis serum corrected calcium. This is not ionized, but rather total calcium here, but overall, no significant differences. So if higher dialysate bicarbonate concentrations are potentially inducing lower calcium values and lower potassium values post-dialysis, could this potentially be leading to an increased risk of adverse cardiovascular related outcomes by way of arrhythmias, hemodynamic instability, and hypotension? And there is some literature to suggest that yes, this might be occurring. And these are studies, again, that were included in our review. And there are some trials that have shown an increased risk of intradialytic hypotension with the use of higher dialysate bicarbonate. However, the literature is not entirely consistent. So, for example, the largest RCT in this area reported no difference in this outcome. There is a trial that showed increased QTC prolongation with the use of higher dialysate bicarbonate, but again, the results are not consistent. There also might be a drop in cardiac index that occurs with the use of higher dialysate bicarbonate, but this is based on, again, a small cross-sectional study. And then there are a number of small studies that have shown no difference in the blood pressure-related outcomes. So some suggestion that there might be something there, but the results are not completely consistent. So just to summarize some of this background literature, there really is a focus on pre-dialysis serum bicarbonate concentration and the treatment of metabolic acidosis. This seems to be our primary focus in clinical practice and the primary focus of the guidelines. And because of this, the use of high dialysate bicarbonate concentrations is quite common, but this does have really a limited impact on the pre-dialysis bicarbonate. And we don't routinely measure post-dialysis pH or serum bicarbonate. And because of this, we largely ignore the issue of post-dialysis metabolic alkalosis. However, we do have observational data that suggest a potential signal of harm with the use of high dialysate bicarbonate concentrations. But whether these data are due to confounding or causal remains uncertain. And we are lacking trials examining hard clinical and patient prioritized outcomes in this area. So that brings me to the Dial Bicarb trial, and I'm going to spend the rest of the talk discussing this trial. So this trial aims to answer the following research question. So we'll be looking at in outpatients receiving maintenance hemodialysis, does providing a higher versus lower dialysate bicarbonate concentration alter the risk of all-cause non-elective hospitalizations or all-cause mortality? And this is our primary composite outcome. Our intervention groups for the trial will be a dialysate bicarbonate concentration of 32 millimoles per liter versus 38 millimoles per liter. So this slide summarizes the key methods for the trial. So our plan is to perform open label individual patient randomization. And we will be accomplishing this using an algorithm that uses the OHIP number. And this algorithm will be provided to the included dialysis centers for intervention group assignment. We also plan to use a modified consent model. So this is a pragmatic trial. So we will be using minimal research coordinator and research assistant resources. And so the randomization, the delivery of the intervention, and the conduct of the trial will be largely integrated into clinical practice. So our consent model is very similar to trials like the MyTemp trial and DialMag trial, which I'm sure most of you are familiar with, whereby we are not seeking traditional individual patient consent, but rather we plan to really socialize the intervention in the months leading up to the trial and ensure that nephrologists and patients in the dialysis units are really well informed about the trial and have the opportunity to opt out of the trial should they choose to do so. So both patients can opt out, but also a nephrologist could opt out their patient if they think that the trial is inappropriate for them. We plan to have very broad inclusion criteria. One of the goals of this trial, being pragmatic, is that we really want to include a diverse patient population, and we aim to include patients that are often excluded from research, such as those with cognitive impairment, and we want to maximize the generalizability of our findings. We do plan to exclude patients from the intervention who are getting nocturnal or frequent hemodialysis, as these patients often receive lower dialysate bicarbonate concentrations than those getting a more conventional 3 times per week hemodialysis schedule. So one of probably the hardest decisions about this trial was deciding on the intervention groups. And we recognize that the choices that we have selected are not necessarily perfect, and there are all sorts of different ways to do this trial. And we landed on these two groups after consulting with a lot of nephrologists and also with our patient partners who helped with the design of this trial. And we selected 32 versus 38 for a number of reasons. So, firstly, these ranges of concentration do fall within the current standard of care in Canada and internationally. They can be practically delivered by all dialysis machines across all units. And one of our key goals is we want to ensure that we're within the current standard of care of practice, but we also want to create maximal separation between the groups such that if there truly is a difference in outcomes, that we maximize our ability to detect this. And in discussing with various nephrologists, we wanted to select a range that would be acceptable to most. And based on surveys we've conducted, it does seem that these concentrations are acceptable. So our outcomes, as I mentioned, our primary composite is all-cause mortality and all-cause hospitalizations. And with this being a pragmatic trial, so not only will this be largely integrated into clinical care, but the baseline characteristics of patients and most of our outcomes will be collected using administrative healthcare data. So both mortality and hospitalizations can be determined using ICES data, specifically the CHI-HIDAD database. We also have a plan to collect some extra measures. So we will be collecting as part of sub-studies, whereby we will use more of a traditional individual patient consent model. We will collect some post-dialysis laboratory measures. These are not routinely collected in clinical care, so we can't determine them from administrative data. So we actually have to collect this specifically for the trial. And we also have a plan to collect muscle cramp data as part of a patient-reported outcome. So we have an established method for this because this outcome is already being collected as part of the DIAL-MAG trial. And there is some data, mind you, not terribly robust, to suggest that a higher dialysate bicarbonate might increase the risk of muscle cramping, and this might be mediated through that lower ionized calcium concentration that can occur with a higher dialysate bicarbonate concentration. So when we look at, the sample size and power for the trial, I'm presenting this slide of power for a cluster trial first, because we actually initially had envisioned this to be a cluster trial, so similar to MyTemp and DialMag, whereby we would randomize a whole unit to one particular dialysate bicarbonate concentration rather than individual patients. And this is because we initially did not think that individual randomization would actually be feasible. And you can see that with a cluster trial, there are a lot of patients that are needed to detect a difference or potential difference in the outcome. And because of this large number of patients that was needed, we initially had proposed this to be more of a national trial where we would be including actually 5 provinces from across Canada with up to 144 dialysis units and more than 22,000 patients. And even with all of these patients and over a 4-year follow-up, we would still only have 80% power to detect a rate ratio of 0.85 in our primary outcome. So we are very happy that we now have been able to come up with a method to perform individual randomization using ICES data. You can see that with individual randomization, the efficiency and power of the trial is dramatically increased. So we will now only need just over 4,300 patients. So because of that, we can then limit the trial to Ontario, which really it takes away a lot of logistical and privacy and statistical complicating factors when you're trying to merge data from a bunch of administrative databases from across various provinces. And with this, we'll be able to actually look at a rate ratio of 0.9, so a smaller difference in between the intervention groups. And there are more than 12,000 dialysis patients across Ontario. So if we get really good buy-in and high uptake across the various units, we might actually also be able to reduce this 4-year follow-up, and this will reduce the costs of the trial even further. So in terms of the overall impact, so if we are able to show that a lower dialysate bicarbonate concentration is actually beneficial, this does represent a pretty simple, scalable intervention. The dialysate bicarbonate concentration really can be easily adjusted at the level of the dialysis machine, and this comes at very little to no cost. So we think that the results of this trial will be really readily translatable into clinical practice. In terms of our overall progress thus far with the trial, so we are still in the early stages. We've obtained funding from CIHR and the Accelerating Clinical Trials Consortium for the post-dialysis blood work sub-study. We have submitted the ethics application to CTO. We are working on a pretty robust plan to socialize this intervention with both nephrologists and also patients. So we're increasing the number of patient partners that are involved in the trial and working on developing really robust patient-facing materials that are translated into a number of different languages. We really think it's important, and it's been learned from the prior trials of MyTemp and Dialmag that we really need to beef up how we're informing patients about these types of trials. And this is the first trial like this where we're going to be using the individual randomization patient approach based on OHIP number. And I think that individual randomization does somewhat increase the complexity because you're having patients within the same unit who are randomized to different interventions versus a cluster trial where they're all getting the same thing. So there might be some increased issues with adherence. So we're really working on developing a robust strategy to monitor the adherence to the intervention. And lastly, I just want to acknowledge all of the co-investigators and collaborators. So Dr. Sam Silver from Queen's University is my co-PI, and so we've been working together from the beginning on the development of this trial. Dr. Amit Garg, who is really a pioneer in the space of conducting these types of trials and has provided a lot of mentorship and support. And then our various co-investigators and collaborators from across the country, in particular, including our patient partners who have really contributed immensely to the design of this trial. And so with that, I'll end there, and I'm happy to take any questions.
Thanks very much, Amber. That was a great overview, and congratulations on your success in getting this to lift off. That's awesome.
Thanks.
I will. Swapnil asked me to step in to moderate the questions just because unfortunately he had to leave a bit early. So I see in the chat, Dr. Zimmerman has a question about how this study might interact with the dialysate magnesium trial, and if there's any concerns about patients who might be randomized to high bicarbonate, but also already on low magnesium.
Yeah, so this concern has come up with, I think, everywhere we've submitted this trial to funding for. At least one of the reviewers always mentions this issue of the Dialmag trial. Firstly, I will say, I think initially we weren't sure if there would actually be any overlap in the conduct of the trials, because you know how long these things can take in terms of development. When we had initially envisioned it as a cluster trial, we were thinking of ways that we could adjust for this in the analysis, because we obviously know what unit is assigned to what dialysate magnesium concentration. So we had planned to incorporate that into our randomization strategy. Now I think it's less of a concern that we're doing individual patient randomization. So individual patients within each cluster of dialysate magnesium are going to be randomized. So I think it's really less of a concern. In terms of some sort of interaction, between a lower dialysate magnesium and a higher dialysate bicarbonate concentration, that it's interesting, and I'm not aware of any like good data that would allow us to say, is there going to necessarily be a difference in outcomes? But it's certainly something where we will have that data available. And we could potentially analyze that in terms of looking for any effect modification.
Thank you. Okay, so I think the next question is from the conference room.
We actually have two, if that's okay, two different people so far anyway.
Sounds good.
So maybe quite a few actually. Okay, I'm going to go first because I clicked first. Hi, Amber. It's Yolanta. So I'm kind of, intrigued by the individualized randomization and, the stated goal to really include as many patients as possible, including those that aren't traditionally involved in these trials. So how are you going to ensure, or what strategies do you plan to look at the patient education materials and, the uptake of those materials by patients, and any strategies to look at who is choosing to opt out and how they may be different from a, structurally disadvantaged or other, aspect of their demographics or, factors that, because I worry that, in choosing these opt-out strategies, we're actually just, again, privileging patients who are able to take on these education materials in a different way.
Yeah, so those are, I think, very valid points. And in terms of strategies that we've been discussing, so, Amic has been involved with this, and we've been, brainstorming a lot of different strategies, and he has learned a lot from conducting the MyTemp and DialMag trials. And we're really working on more robust strategies. So one of the strategies that we're hoping to use is really having a very wide network of different types of patient partners. And our plan is to make not only, brochures and pamphlets that can be circulated in the dialysis units, and potentially using patient partners to help circulate those documents as well, and having a point person in the dialysis unit that will actually sign off and say that those documents were circulated. For patients with cognitive impairment, our goal is to also have those circulated to their substitute decision maker or caregiver. We also plan to develop a website for the trial and have recorded materials available on that website so that, patients with significant visual impairment, patients who may not speak English, having those materials available, not only the written ones in different languages, but also recorded versions of things in different languages. It's come to our attention, for example, with our focus to hopefully, include Indigenous patients in the trial, that some of the Indigenous languages are only spoken and not written. So that's a consideration. And we're working on having a broad representation of patient partners to ensure that some of those issues with respect to how best can we ensure that these are really circulated in a diverse way that is acceptable to a lot of different types of patients. I think this issue of, ensuring that we don't have a large number of patients opting out is a valid concern. The previous trials with DialMag and MyTemp would suggest that really a minority of patients do opt out of this trial. But we do need to ensure that the nephrologists as well that are in the units are really supportive of the trial, because I think that is also part of not having a lot of patients opting out of the intervention, and that the materials are explaining the trial in the correct way such that it's not encouraging an opt-out strategy. Now, we will not be able to, have individual names or OHIP numbers of the patients who do choose to opt out of the trial. Due to the way that we're conducting the trial, that would sort of violate some of the ethical and privacy concerns. So we won't have that detailed level of information. And you're very correct that this trial does kind of fall apart if we find that we're getting a lot of patients who are opting out. But previous trials conducted using a similar methodology would suggest that that should not be a concern, and that generally there is very high buy-in and high uptake of the intervention.
Thanks, Amber. I think still in the conference room. Is that okay, Ted? One more from the conference room?
Yeah, definitely.
Okay. Two more.
Two more.
Okay, sorry.
Hi, Amber. It's Brendan. I really enjoyed the presentation.
Hi.
It's a great area for research, and I think you did a great job at showing how the observational data really doesn't help us because of just the multiple layers of confounding. Dietary acid load, residual kidney function, even things like your dose of calcium carbonate. All of this is going to affect your pre-dialysis bicarbonate. And you also show that, right now that the standard of care really does seem to be to individualize the bicarbonate concentration so as to achieve kind of a normal-ish bicarbonate pre. And so my question is, I guess you could have designed the study two ways. You could have either had different pre-dialysis bicarbonate targets, 20 to 23 versus 23 and above, or what you've chosen to do, which is a standard bicarbonate bath in two groups. And to me, when I was listening, I was thinking, well, isn't this a little bit like randomizing people to a 2K bath or a 3K bath without taking into account where the pre-dialysis K is? And I'm just wondering, because I'm sure you guys considered this question, why did you choose the bicarbonate bath approach as opposed to a pre-dialysis bicarbonate approach?
Yeah, so this is something that that we went back and forth on a lot. I will say this issue of individualization, and while individualization is common, I would say that it's just as common or less common depending on the region that you look at in terms of a standardized practice. So when you look at the DOPS data, there were about half of the units included there internationally that were using an individualized approach compared to a standardized approach. And they define standardized by greater than or equal to 90% of the patients in a unit receiving the same concentration. And when we did our survey data, there were, while there were quite a few units using an individualized approach, there were actually, more units using a standardized approach. And when I look at, for example, our local units in Hamilton, we have probably 98% or greater of patients who are receiving a 35 millimole per liter dialysate bicarbonate concentration across the board. So I think that the issue of individualization, while it is common, there's a lot of units who are just using a one and done approach for all of their patients. So I think taking that approach is not really outside of what we're already doing. And then also too, there's this issue of the fact that individualization really does not seem to impact the pre-dialysis serum bicarbonate concentration much. I know it seems counterintuitive, but the data would really suggest that it doesn't have much of an impact. And so we are probably just, like nephrologists like to do, tinkering around with blood work results and thinking that we're making a difference for the patient. And then there's this bigger issue of the fact that in particular for a pragmatic trial, when you increase the complexity of the intervention, you're going to increase, just the overall complexity and logistics in terms of monitoring the adherence for that intervention. And when we actually ask some of the units, what they're doing in terms of individualization, I would say that a lot of the units are practicing sort of pseudo individualization, where they just pick between two concentrations depending on the pre-dialysis serum bicarbonate. So they might pick between, for example, 35 or 40. And so we did worry that with individualization, really what we might end up comparing is, two of the same dialysate bicarbonate concentrations. So we might have, for example, a standard group where, let's say, we look at 35 or 38, and then we have an individualized group. And then maybe we also need a third group of a lower concentration. But in the individualized group, you might just get sort of regression to the mean where most of the patients end up on a 35 millimole per liter bath. And then you're comparing apples to apples and reducing the chances that you're going to detect a difference. So I think your point is fair, like that an individualized approach might be something that also needs to be tested. We just, after a lot of thought and discussion, we decided not to include this as one of our approaches.
Thanks.
Just one more question from the conference room. Is there any difference in cost or plastic waste or resource use between a 32 and a 38 concentration bath, or does it end up being sort of a wash?
So it is mostly a wash. When I asked our tech, the only time it might be an issue is when you are like increasing the dialysate flow or doing something else that is outside the realm of usual practice. So in that situation, a 38 millimole per liter bath might have a nominal increased cost associated with it. But for the most part, it's a wash and there really is no cost difference between the two of them.
Thank you.
Thanks.
I think
Okay,
we're good from the
Peter.
conference room.
Yeah. Hi, Amber.
Hi.
That was great, and I fully support your trial. I wanted to go back and comment and question about your background part. I think the practice of high bicarb or individualizing to high bicarb bath is from the olden days when I trained, when dose of dialysis was about half as much, and low flow, smaller membranes, and many people were acidotic, and there was lots of literature about how to get the bicarb up and etc. And I guess those old farts who trained back then are still the opinion leaders who say you should use a high bicarb, even though the dose of dialysis is much higher now. On the individualizing thing, I bet Ottawa's a unit that says we individualize, but it's mostly, I think, initial order, somebody picks a number out of their hat and nobody ever looks at it again. Because I certainly see, I occasionally look at the bicarbonate, probably not enough, but I'm interested in acid base. And I often see people whose pre-dialysis bicarb is 26. The person who's not eating, often the frail, small people who's getting a huge dose of dialysis. And nobody's ever individualized them to a lower bicarb to try to prevent the probably quite severe alkalosis they have. And I'm glad you touched on the potential ill effects of alkalosis. And, it hadn't occurred to me that you are removing less potassium. And I think that's a really key point. So, I think if nothing else after this, most of us might look at pre-dialysis bicarbs a bit more than we have, because I don't think anybody looks at them. So thanks for that. I think your trial is a great idea.
Well, thank you. Yeah, that is one worry that kind of has occurred to me in thinking through this is, okay, once we get this trial launched, and then people will know, given its open label, if their patient is on a 32 versus 38, are people going to start paying more attention to the pre-dialysis bicarb? And if they see any subtle changes, is it going to, make them nervous? Because I have to admit, for example, with the Dialmag trial, We don't routinely measure serum magnesium in the outpatient setting, but we often get patients who are admitted and they get serum magnesiums drawn. And I'm seeing now with patients who are randomized to the higher dialysate magnesium, they're often have high serum magnesium levels in the inpatient setting. And I have received a question from one of our nephrologists, you know, what should I be doing about this? Should I be adjusting down their dialysate magnesium? And, you know, largely the response has just been, you know, ignore it unless they're, you know, looking like they're dangerously high and just let it go. So your point is taken that people might start to pay more attention to pre-dialysis serum bicarbonate than they previously were.
Yeah, so if in this trial my patient is randomized to the 38 and their pre-dialysis bicarb is 30, as the reasons mentioned, should I be withdrawing them and saying no, 38's dangerous for you, or should I be leaving them alone?
Yeah, so we're hoping that, you know, a lot of that will get selected out prior to the actual rollout of the trial. So let's say, for example, I can think of a handful of patients that I have whose pre-dialysis values are really wonky for whatever reason. And, you know, you might make the decision as their nephrologist, I want this particular patient to not be assigned and not be randomized because I think they need something else. And so hopefully they would get selected out prior to the trial. But during the trial, if you're the treating nephrologist and you think, no, this is not appropriate, I mean, certainly it is within your right as their nephrologist to withdraw them.
Thanks very much, Amber. So we're just past 9 o'clock. Are you able to stay for one final question here?
Yep.
Okay, so Mark Haney asked in the chat here, if the mechanism is through low potassium or ionized calcium, did you consider stratifying on either of these, or is stratification just too hard in this type of randomization?
Yeah, you know, we could, so the issue is that we don't actually have that data available. So all we have available is what is routinely collected as part of clinical care. So we don't have post-dialysis measures. So yes, those will be, you know, looked at in a subset of patients as part of the sub-study, but we actually have to draw those measures as part of the trial. So I'm sure you're aware, we don't, you know, routinely measure post-dialysis potassium and in particular ionized calcium post-dialysis. So, you know, we hadn't really thought of it, but it also would not be possible.
Well, thank you again. That was a great talk, and we're excited to see the trial get rolling.
Okay, thank you.
Okay, thanks.
Okay, bye.
Bye.